Hi, everybody. I'm Dr. Deborah Cohen from Kaiser Permanente, and I'm going to talk to you about a project we've been working on for the past year and a half, a system of observing masking and distancing, which is a project that began after the pandemic started. My team was supposed to be working on studying playgrounds, but because playgrounds closed, we shifted and developed a new method to just monitor how well people were adhering to the guidance to wear masks and keep their distance, because at the time that was the only way to protect oneself and family members against getting the infection. And so we developed a method which was basically observing people as they go by to see if they were wearing a mask correctly, also documenting their age group, their gender, their race, ethnicity, their activity level, their mode of transport, the number of people in their group, and whether they were keeping at least a 6-foot distance from another person. And after we developed this method, we did measurements locally where our team was, mainly in Philadelphia. But then we decided to offer this to researchers around the country, to see if we could get a national picture of what was happening with adherence to the masking and distancing guidelines. And so we were able to recruit about a dozen different universities across the country, and they trained their students in doing the observations, and we collected data on over 100,000 people in 126 cities across the US. And so what I'd like to do is introduce a colleague, Kathleen Manuel, who also worked in collecting data on this topic. Kathleen, tell us about your experience.
So hi everyone, my name is Kathleen Manuel, and I'm a senior research associate at the Michael Dell Center for Healthy Living at the UTHealth School of Public Health in Austin, Texas. So in collaborating with the SOMAD project, I led the Texas observations and data with our statistician, Roger Malkani, and our faculty sponsor, Dr. Deanna Helsher. Among our team, we had about 8 students data collect with over, I believe it was 22,000 data collected in 3 different cities in Texas. So we collected data at Austin, Houston, and San Antonio. And then regarding our SOMAD experience, we wanted to share 3 of our key findings. So the first is that the odds of mask use was particularly high when local policy at some locations, sites required individuals to wear masks. Secondly, among our location types, the odds of mask was highest at the farmers markets compared to the university, parks, and trail locations. Third, increase in daily number of statewide COVID-19 cases associated with higher odds of mask use. So in addition with collaborating in the SOMAD project, I believe it could provided a great opportunity for our graduate students to experience field work and have a chance to observe data collection. So from this, 2 of our practicum students were able to submit an abstract to the annual Texas Public Health Association conference that will be held this May. And both their abstracts were accepted, which we're very excited about since this will be their first presentation and conference as well. Lastly, we plan to submit a manuscript for the Texas data and hope to release it soon after we finish analyzing all of our 22,000 data collection. Thank you.
Thanks very much, Kathleen. So I'd like to introduce Nicole Smith from CSU Fresno.
Thank you, Dr. Cohen. My name is Nicole Smith. I'm an associate professor in the Department of Kinesiology at Fresno State University. We also formed a team when we heard about the opportunity to engage in SOMAD. And we formed a team with faculty from 5 different departments and invited students from across the university to participate. We trained about 48 people to collect data, and about 35 of those persisted throughout the project. They collected data every week on 2 different days at an established location, And we collected data from about the middle of February of 2021 until the very beginning of May. During that time, our observers observed a little more than 35,000 people. We actually had public health interns from our Department of Public Health undergraduate program go out and monitor and collect reliabilities on our observations. They went out to see observers about once every 2 weeks. And for each observer had a public health intern come and do a paired observation on 4 different occasions. The reliabilities were quite high. I think that was one of the most important things that we found was that we were able to train undergraduate researchers to use this tool. They were reliable and they persisted through data collection. They were really excited to be involved in a project that they thought was meaningful and was adding value at the time during, the COVID pandemic. We presented our data and some of our findings that we found. We presented at the American Public Health Association conference last October. We found that males were more likely to be seen, white males were more likely to be seen without a mask in our population. We also found that people were more likely to be wearing a mask where policies were posted. And we had locations that were balanced between going to kind of the outside area of commercial centers and also on parks and trails. People were more likely to wear a mask when they were in a commercial center location where the signs were posted and where people were holding them accountable for wearing a mask to enter a location. Out in parks and trails, it was interesting. In our parks, there were signs posted at the entrance of our parks. But when you got into the park and walked around to look at what people were actually doing, they were not adhering to mask policy at those park locations. And only when we saw structured programming occurring in the park did we see people following the guidelines, and that would include like a school program, an after-school program being held in a park with supervision. So it was really interesting. Key takeaways for us in the end were that we could organize and mobilize and train people up to collect meaningful data and to collect a significant amount of data. We also learned that there was a real value in being able to use the mechanism of like digital data entry. We actually collected our data on paper pencil. It was a decision our team made early on because we had some challenges that we perceived would get in the way with digital. But in the long run, we ended up with so much data that it became a burden to process the data quickly. So there was a lot of value in the digital method of data entry in this project. And those were really the key takeaways for us. We really are thankful that we had the opportunity to engage, and we're thankful to be able to share our story today.
Thanks very much, Nicole. Dr. So, you had students that also collected data. Do you want to tell us what your experience was?
Yes, thank you. Well, before I explain my experiences and share our students' experiences, first I would like to thank you, all of you, for joining today on behalf of the International Organization for Health, Sports, and Kinesiology to share your experiences and research expertise in this research endeavor, SOMAD. Our students had a great experience in direct observation through a SOMAD system. And since last year, our students could collect up to close to 20,000 data points, which has been really interesting for our students' effort. Has been really effective for my teaching as well, and also public health in the San Bernardino County office as well. And this one has served for public health as well as community services and students' high impact practices for student learning and experiences as well. And I'm still working on data collection and data reliability and testability using SOMAD. And again, thank you so much for providing us with this wonderful opportunity using the SOMAD and SOPARC basis. And I think this session will be very useful for our members in IOHSK who is interested in public health and their research effort using direct observation and SOMAD, especially in the time of COVID-19. And thank you so much.
Okay, and we're joined by Dr. Tom McKenzie, who is actually one of the people who founded the concept of systematic direct observation, has developed it in many different ways. And Dr. McKenzie, do you want to talk a little bit about how SOMAD sort of fit into this whole area of systematic direct observation and your experience with the national collaboration? You're on mute. Yeah, sorry.
Thank you so much. I'm very pleased that that you were able, Dr. Cohen was able to extend some of our musings in San Diego. And we were just simply watching people on the street and saw that they weren't observing the rules. So identified that, hey, we could do direct observation to be able to provide feedback to communities and target particular groups of individuals. So thank you for doing that. SOMAD is an extension of other momentary time sampling tools we've done, such as SOPLAY and SOPARC, in which an area is scanned and people are identified as falling within particular categories. And so I'm very much appreciative of Dr. Cohen for leading this effort and for all of the rest of the investigators for taking over. And I appreciate that the tool is reliable and particularly usable for, I think that in a public health setting, those are very important qualities for anything. And I'm a prime believer in systematic observation rather than other methods for generating data, such as self-reports. What you see is what you get. So thank you.
Okay, well, thank you. So I just want to sum up what happened. So as I mentioned, we had like a dozen or more different universities collaborating and collecting data. And we aggregated all of the data to see how things changed over time and how adherence was associated with different policies. And what we found nationally, you know, when we control for all of the different factors, was that having a policy that mandated mask use was associated with a threefold increase in compliance. So policy is very important. If it was just recommended, it was only like, I think 1.8 times the odds of compliance compared to having no recommendation whatsoever. So we found that policy matters. We also did find many disparities. So as Nicole had mentioned, I think Kathleen also found out that males were less likely to use masks than females. We had the highest compliance among Asians of all the ethnic groups. We also had seniors more compliant than other age groups. And of course, they're at highest risk, so that makes sense. We found people in vigorous activity were less likely to use it than people that were moderate or sedentary, but moderate used it the most. I think it was related to them being more in commercial areas. Commercial areas, again, people wore masks more than in parks and playgrounds. So there were important implications for policy. We have many of the different collaborating groups shared findings with their local health departments. And our hope is that this kind of information is going to influence policy and practices in the future if this continues or if we have any resurgences of this type of infectious disease. So the other acknowledgement is that we did get funding for the dissemination of the methods from the organization Resolve to Save Lives. who were very supportive of this work. And overall, it was a very positive experience, not just for, getting the results, but all of the data collectors, were introduced to this method of direct observation. And we found out that it's pretty easy to train people. People did very well with doing their observations and submitting data, and it made the project a success. So I don't know if I guess we can't have questions and answers, but Dr. So, do you have anything you want to add?
Well, thank you so much for your wonderful sharing and presentation. I think that is enough for SOMAD. First, we talked about the brief history of SOMAD and some research effort among research collaborators, and also national effort to collect data to disseminate the data for the policy, the recommendation as well. I know this is the ongoing research ending by March 31st, and we look forward to seeing more data that will help our public health. And again, thank you so much for your time and disseminating your effort and your research with so many members around the world. Thank you so much.
Thank you for including us.